Mrs. Mauer was over in my office making sure we had the proper stuff. It's a neat lab because we look at we do look at some slides, but I kind of give you the lowdown on blood. You can do your own ABO testing. You can do your own hemoglobins and hematocrits, random sugars if you're interested in that. Kind of fun. So if you don't mind sticking yourself, don't ask me to stick anybody. I'm not doing it. Oh, you can do it. You're a little nothing. I didn't say. I know nothing. See, bless you. All right, so let us start the events of the day. Thank you very much. So you're stuck listening to me talk. That's all right. Bring a good book. Computer games. It's terrible. I was up too late. Us old people can't stay up later than that. Not a great game. Good. I mean, it got better at the end, but certainly not a great game at all. So I was rooting for San Francisco, but not for, I beg your pardon, for Kansas City. So I wasn't unhappy necessarily with the result. This is where we left it. Alphas and betas. So there's not a lot left here. We do look at some of the pharmacology that's there. Alpha 1s and alpha 2s, betas 1, 2, 3, and you're going to see the example. And so we talked about this a little bit. It's anytime you're dealing, whether it's a neurotransmitter, whether it's a compound that you get or a pharmaceutical you get for yourself, a lot of times it's the nature of the receptor. It doesn't always work the same way on everyone. And in today's modern pharmacology, as I was talking about with serotonin reuptake agents or serotonin agents that are designed, they're receptor specific these days. So the advances in pharmacology are considerable. All the products don't work, but they go through the appropriate testing, which a lot of times you don't know. And that's the difficulty with some of these agents. They come out as the best thing ever, and then a year or two later, then they stop using because they didn't see the side effects of longer term use or some bizarre things that occur. So again, it depends on the receptor. Beta 1 increases heart rate. Beta 2, smooth muscles of the bronchi, dilates. And so again, you can see all of those, the differences between them. So as we take a look at them, when we talk about the nicotinic receptors for acetylcholine, or what we call cholinergics, meaning they are made active by the presence of acetylcholine, all postganglionic neurons, adrenal medulla, also called neuromuscular junction, and also the neuromuscular junction. So basically, the release of acetylcholine by the preganglionic nerve is excitation, and we know about the neuromuscular junction. The distinction is the muscarinics, so the parasympathetic target organs. The only exception, again, memorize the exception, is it slows down cardiac muscle. We do the heart unit, we'll go into that in a certain degree of depth. And as you can see, the targets are somewhat limited, and particularly the one we see that, on the other hand, is excitatory, but it's an oddball because it's in the sympathetic, is sweat glands. So it causes an increase in perspiration, typically associated with fight or flight. We'll get to that as well. That brings us to this whole subset, beta 1s, beta 2s, beta 3s. So beta 1s, principally the heart, and when it's norepinephrine, it's both, we call it, as you'll see down the road, when we do heart, chronotropic and inotropic, which means it increases heart rate and force of contraction, where acetylcholine from the vagus is only chronotropic. It only decreases heart rate. It doesn't interact with force of contraction. That's an important distinction down the road, as you can see. And then, of course, this is when we, again, review something we're going to touch on a couple of times coming up between blood pressure, between the kidney, and maybe even a little bit in the endocrine system, the renin-angiotensin-aldosterone mechanism, as you can see. But in kidneys and adipose tissue, it also is stimulatory, particularly for the renin. So the beta 2, lungs and most other sympathetic organs, abundant in blood vessels serving the heart, liver, and skeletal muscle. Why is that significant? As we get to fight or flight, where do we divert blood flow? We divert blood flow in fight or flight when you have to run, act, fight for survival, to your heart, blood vessels going to skeletal muscles, and the liver to produce additional energy storage, particularly glycogenolysis. That's all coming from there. So heart, liver, and skeletal muscle affects mostly inhibitory in the sense that it's inhibitory in the sense of its direct effect on the smooth muscle. So it leads to dilation, vessels and bronchioles, smooth, and also it dilates, in this particular case, the walls of digestive and urinary organs and relaxing the uterus. So genitourinary and digestive are suppressed because in fight or flight, those systems are shut down to trace blood flow amounts, just enough to keep them functional when they're needed again. But you're redirecting your resources for the purposes of survival. Again, it's an emergency type of situation. So they're really important. And beta 3 is an adipose. Again, now we're looking for, and perhaps we see this again as we get to the point where we have to utilize fats alternatively. So, in the pecking order of energy resources, we always use carbs first, or carbohydrate-based compounds, whether they're carbs, whether they're complex, simple, sugar, alcohols, whatever. Okay, alcohol in and of itself, whatever. And then we get to fats. And so that, at that point, that kicks in. So when you're seeing a fat burn, when they say that on a treadmill and you want to concentrate your activity for that, basically you're triggering beta 3 receptors. Alpha 1s and alpha 2s, okay, virtually, and again, constricts the blood vessels, so it's excitatory. Visceral organ sphincters, so again, you don't have to use the bathroom for any reason. Dilating the pupils of the eye, that's basically tensing that ciliary muscle. So virtually all sympathetic target organs, especially blood vessels serving the skin, mucosa, viscera, kidneys, and salivary. We don't want to use any of this. So we don't want to direct blood supply to places that we're not using immediately. Again, it's all about survival mode. And that's how you understand this system. The easiest way, remember all the events of fight or flight, and the opposite is parasympathetic, fight or flight is sympathetic. It's the only time we see a remarkable push to one side or the other. The rest of the time, they're working in concert. And as you can see, membranes of adrenergic axon, terminals in the pancreas. Okay. And so you can see here, again, somewhat associated with fight or flight, inhibits release from adrenergic norepinephrine, inhibits insulin secretion. So typically you're trying to use the available glucose or get it from other sources. Insulin is typically something, and we talk about it a bit when we get to the physiology of diabetes, is designed for digestion when you've consumed a meal. Think of it that way. And that'd be the opposite of fight or flight. We want a lot of blood supply to our gastrointestinal and our genitourinary resources. Here we go. So, nicotinic agents. These are famous. Okay, nicotine. Okay, all postganglionic receptors plus nerves in the CNS, typically stimulatory, causes your blood pressure to rise. Okay, so, and this is if you're familiar with Nicorette type gums or nicotine patches. The whole idea is nicotine is obviously the addictive substance. I am a WLA on this, world's leading authority. Okay, it's interesting, those products, the trouble is when they step them down, they have 3 levels if you didn't know. High level, which does really curtail your nicotine. Once you get to medium and low levels, I mean, it takes more willpower than I had. I was smoking with the medium and low level. The high level nicotine patches, And like all these things, they make you feel funky because of all the other stimulatory effects that are there. But that's when they talk about this is obviously mimicking its effects. And so we get the term parasympathomimic, okay, muscarinic agents, because the vast number of muscarinic agents that are associated with the parasympathetic nervous system. So, important word, mimics, just as we begin to see sympathomimetic or sympatholytic, we're even going to see parasympathetolytic. So, mimicking the effects, a couple of these were originally used. I do not know what the current technology is for treating glaucoma, but this would be one of the ways that this works. Is opens the drainage pores. And I don't know what, I think these are mostly in drop form, at least they were. And the botanical, so it's sort of a take it from somebody with, most times prostate related. And nowadays there's something called Flomax, which is used a lot, which seems to relax the bladder directly. And I was taking it because it was more of a secondary problem to the bladder cancer that I had. But the problem with the botanical and related agents, okay, the difficulty increasing the contraction didn't necessarily release the sphincter. So, and those agents were sometimes difficult to tolerate. You're already familiar with acetylcholinesterase inhibitors, and basically they limit the degradation of acetylcholine. So all receptors prolong its effect. And now, is it useful as neostigmine when we're dealing with myasthenia gravis, with the autoimmune disease of the neuromuscular junction? For sure. However, here we have chemical weapons. Sarin, VX nerve gas, all very, very famous. Agents similar to widely used insecticides. We learned about DDT was sort of derived with some of these agents. People were using that. And so that the whole idea, it's horrible. You can see graphically, there's been a couple of the movie The Rock was the late Sean Connery and Nicolas Cage in 1998 showed the effects of, they were like VX gas. They took over Alcatraz. Good movie. And the other one, for you people who liked Homeland, the series on Showtime, they showed the effects of that on a terrorist act. So if you were fans of that, or you go back and look at it, that would be a really good show. Who's that crazy lady who does that? Claire Danes. Claire Danes, you know what I'm talking about? She does not have to go out of her way. It's like Jack Nicholson. They don't have to play crazy. They don't have to go out of their way. She's great. Anybody ever see Stardust? That's Robert De Niro as a cross-dressing air pirate in a mythical world. Just say it. And she plays a star that the lead character is trying to protect. It's very good. I know. Weird offbeat. Now it brings us to sympathomimetics and sympatholytics. Mimics it, opposes it. Okay, adrenergic receptors, enhances it. Classic, Venol. Really, again, the epinephrine works faster when we're talking about EpiPens and anaphylactic shock, but for typical asthmatics, they may have to resort to that, but the Ventolin has been much more effective with less complications. So binds to the beta 2 receptors. Now remember I told you a little bit about Sudafed and the whole idea of using that for amphetamines. Because of that, the agent that we see today, if you buy a cold tablet or a decongestant commercially, is phenylephrine. It has certain amounts of similarities, and you can see it binds to alpha-1 receptors, so it's shrinking a little bit of those membranes. That produces that. Frankly, being somebody who's had that problem over the years, most of the doctors are recommending those Nasacort, those cortisone sprays, a lot that now you can get over the counter. They're very effective for that. A lot of the big problem with these products, particularly when they were in sprays, is they cause the membranes to dry, and there was a lot of problems with nose. So the Nasacort was a little bit better for that. And then, keeping the membranes moist, you could take a Q-tip with Neosporin or something like that, and it worked very effectively. And this is one that we don't use anymore, propanolol. It's a classic beta blocker. So there were the problem with beta blockers and hypertension. They had a lot of their. They were very effective at treating the hypertension by slowing down by basically hating to dilate blood vessels and slowing down heart rate. The good news, the bad news was they had more side effects than people knew. People had a lot of problems, and we do with a lot of blood pressure medications with postural hypertension. They get up too fast, they feel dizzy. So the sensors that we're going to cover in blood pressure talk about that, and that's a real problem for somebody. Here's what I do in the morning. If I get up, when I have to go to the bathroom in the middle of the night, I'm old, or otherwise. Okay, I sit up, I wait a tick, I stand up, I hold on my desk, I wait a tick or the nightstand, then I'm going. What? High blood pressure. But I have blood. It's because the blood pressure is low. Mine is a side effect of the agents. Okay, I take 2 blood pressure medicines. And what they do is they alter the efficiency of the sensors in your carotid and in your aortic area. Okay, and those are pressure sensors. They're less sensitive, so normally they're going to keep the blood flow to your head. Low blood pressure, you don't want to take anything to elevate your blood pressure, just be careful with it. So it's we see it more with elderly. In the old days, we didn't have cell phones that were on a nightstand. You heard a phone, oh my God, you heard the doorbell ring. Jumped up to see who it was, you heard a noise now. That's because there are a lot of people with boom. Postural hypotension. That's with a change of position. You'll get your people with low blood pressure live longer. So you're good. What? Really? Interesting. For your blood pressure, your top is 88. Woo! See, if I walked in there, okay, when I was in kidney failure and went into St. Margaret's Hospital, and this was salmonella related kidney failure, from a toxin. My blood pressure was barely 90 palpable. I was in ICU for 3 days. No view. Moving on. Okay, so here it is, dual innervation. So basically, and I love the dynamic antagonism because it's the beauty. It's homeostasis 101. We are a little more active. Something else slows something else down. We're slowing down and makes something else more active. So they're partially active, and we call it the tone. Again, fight or flight is really the closest thing to purely one. We don't see it with parasympathetic, but pure sympathetic is about fight or flight is as close. So in general, heart, respiratory rates slows down gastric, GI, and genitourinary function. Parasympathetic slows down heart and respiratory. So they call it the rest and digest, and it's the action division. Sympathetic is all about blood vessel, smooth muscle. That's the big one with blood pressure. Just what we were talking about. So that's why we don't see kidney being innervated by parasympathetic. It's indirect. If we close down the blood supply or limit it, the kidneys are less active. The more blood supply, the more urine you make, the more you have to go. So, continual state. And what's really vital about this is the bottom number of what they call the diastolic of your blood pressure. That's the one doctors are interested in. That's the resting tension in the system. If those vessels are too taut, your heart has to work harder to push the blood. It's like heart's just another muscle. The harder it works, the bigger it gets, the stronger it has to work. And it increases in size. And we get what we call cardiomegaly, an enlarged heart. That's not unlike other muscle systems. It's like if you're working on your, on your upper extremity or your lower extremity for whatever you're doing it for, you're looking at desired result. Your heart's not good. When it says, again, so we looked at the muscles. When that muscle is so thickened, it effectively is much harder to generate the appropriate dynamic. It has to have a certain amount of stretch. We'll look at that when we look at heart physiology. Sir. Very bad. That's the biggest complication of high blood pressure. And what happens is your heart becomes less effective. The heart is designed to be stretched passively. When it is thickened, it can't stretch, and it does not generate the force of contraction, which is necessary. And becomes and you'll see with heart and respiratory, it's all a vicious cycle because they're all interconnected. It's a very interesting system, but it's a problematic system. So, and again, this is the whole idea. Blood pressure rises, they fire less, okay? And it'll slow down. So by and large, most of us, we control this without thinking about it. People, if you have hereditary high blood pressure, it's okay. As with somebody like me, they'll give you medicine for this. And we can control that with comparatively limited side effects. Okay. Parasympathetic dominates heart, digestive, urinary, slows the heart, parasympathetic tone. Again, sympathetic can override stress. Let sympathetic take over because that's theoretically going to keep you alive. And again, drugs that block parasympathetic, we use this, but the downside, this is what we were talking about before. The downside with parasympatholytic agents is they have these kinds of problems. Gastrointestinal and urinary problems. So you got to be, for those of you going into a medical field, you can't impact the system without impacting another system. You have to be very cognizant. There's no easy recipe for it. Some things are very straightforward. Somebody has a broken bone and you set it and you put a pin or a screw in it. Okay, business done. Right? When you're dealing with more complicated problems, so some of them it doesn't mean that there's a lack of. You have to be extraordinarily talented to put the pin or the screw and reset the fracture and not cause any damage. Well, that's true. Okay, it doesn't mean less. It's just a different subset of things that you're looking at. So the best, hey, look, sexual response is certainly the best example. Parasympathetic, because the parasympathetic stimulation is what causes vasodilation, and that increased blood flow leads to the erectile phenomenon, both male and female. But what causes ejaculation or the reflex contraction or orgasm, whatever you want to call it, climax, that's sympathetic. So they're perfectly aligned in that. So all of these. So this is some of the interesting thing about, and when I talk about unique role, this is what it does. So adrenal medulla, that unusual ganglion that produces wide-ranging effects. Again, the only one that goes to the skin with perspiration, hair standing on end, whatever you want to call it, the kidneys, and because of that, all blood vessels, because of all blood vessels, therefore the kidneys. So again, if we're active, sympathetic, with body temperature rises to compensate for the generation of heat, skin blood vessels dilate, heat escapes, perspiration cools. Renin from the kidneys, okay, they'll increase blood pressure, which is an offshoot of sympathetic. It reinforces it. metabolic rate. We have to, again, glycogenolysis to make more glucose. And when the glucose goes down, you get that other layer with lipolysis. Again, think of what you're trying to accomplish with that. So, as you can see, a lot of it plays a role in the neurotransmitter. In parasympathetic, it's tiny corrections because acetylcholinesterase always there takes it away very quickly, as opposed to sympathetic effects. And I'll get into why that was significant years ago. I told you a little bit about some of the products that were marketed by GNC and others is weight, because they've been trying to, like, people want a magic pill, they can lose weight. Whatever, what's that one, the diet for the diabetics that everybody uses? Yeah. It's like, oh my God. People were fine. Oh, I can just take this and do whatever I want. I'm going to lose weight. Great. There's no panacea. What it comes? It's Ozempic. That's it. You're right. And you see all the commercials and everything, and now all of a sudden, oh my God, what's happening to people? We see this phenomena repetitively. So why are sympathetic changes in our context, and I don't know enough about the Ozempic to comment on it, I should look that up for our diabetic unit, which is coming up, is inactivated more slowly, okay? Their effects are more prolonged. Again, they are pretty much only removed by reuptake. There's no additional layer. There's no acetylcholinesterase analog for epinephrine and norepinephrine. Moreover, the release of norepinephrine and epinephrine isn't confined to the parasympathetic nervous system. What does the adrenal medulla do? It releases it into the bloodstream. So you have a prolonged effect of something that inherently takes longer. And I'm not going to go through the chart. You can go through it, but you should. If you're memorizing one, this is the one. Memorize one, the other's the opposite. Get to that in a second. And I don't know if they have the slide, and maybe we'll get to it. The problem was that the norepinephrine and the epinephrine worked on different areas when they were released by these, like GNC agents that were ephedrine analogs that we were talking about before. And what they did is they elevated blood pressure, they made heat tolerance, and that week there was a very famous player for the Vikings back in, I'm going to tell you, he's an all-pro left tackle, Corey Stringer. And they were up at one of these they did in Minnesota, they did their summer camp very north, but it was an unusually hot summer. And he died from the heat because they had him on one of these. He was 6'4", 377. He was out of Ohio State. And he succumbed to hyperthermia on the practice field. At that time, they did 2-a-days in pads, which they don't do today. And again, I think it was at GD State, which has a very good men's hockey team for kids. And he died. That was in the summer. The following spring training, there was a pitcher in Baltimore who was on the same thing. It was a very good pitcher. 235, 240. He died. Go ahead. Pardon me? Very nitric oxide? Indirectly. What happens when your blood vessels are stretched, okay, they release nitric oxide to combat that because it naturally vasodilates. When your atria are stretched, they release, as you're going to see, atrial natriuretic peptide, which is designed to get rid of extra water in the system. So nitric oxide combats it. It's the point that they overwhelm the mechanism, if you want to think of it that way. That's the difficulty with it. I mean, I think when I was very much heavier, when I was like in college, I mean, I got that heat thing on the golf course. I just got over, and we would take, the old days, we'd take salt tablets and things like that. And we're kids. We're walking around carrying our bag or pulling a cart. We're not taking the truck. Now you can't do that on the old course at St. Andrews. You have to walk, have a caddy, or walk. Period. End of sentence. But I thought I was having heat stroke. My buddy who was down, we were together then. I mean, I was happy to get home. It's crazy. So a lot of times your own physical condition impacts that adversely. And mine was adverse to start with. We will spend some time about this. I have touched on it in passing. Autonomic neuropathy. Okay. This is and common is the watchword. In my practice, 65 or more percent of diabetics, mostly older, I would say half of them had some form of what we call diabetic peripheral neuropathy. They were, I mean, I'll tell you the same anecdote. If I did it before, don't stop me. And they start by losing sensation, they lose motor activity, the sensors in their extremities, they can't tell if the water's hot or cold. They can't feel, if they're walking barefoot, they couldn't feel a tack that they would step on. I can't even tell you how many times in my practice I had men particularly who were doing more of the those kinds of trade work jobs. I remember one guy, he comes in, the blood's coming out of my shoe. Look at it. And he's got a carpet tack. Yo! Didn't even know he had it. I mean, he succumbed. Not to that, but not within the next 10 years. A big, heavy diabetic guy didn't take care of himself. So it affects a lot of systems. It normally starts sensory wise, then it becomes motor. Sure, I shared the story with you that truly my favorite patient for all those years, and I think he died in 2004 after having an amputation. I kept the leg on for about 20 years. I was able to remove infected bone from his leg without benefit. Totally insensitive. Just to give you some ideas. So the anecdote is about sexual dysfunction. And if I didn't tell you, a guy came in my office, referred by his diabetologist, never took care of himself, enormous, mountain man, big beard, one of those guys. What did they do? Truck driver, shot in a beer. They drank their lunch. Boilermakers, shots followed by beer. Okay. What? He was here. What got him to go to the diabetologist where he never took his insulin or watched his diet? Early sign, he's 36 years old. All of a sudden, performance issues. And that got his attention. I saw him once and then another time by the end of a 6 to 9 month period, he had probably lost 50 to 100 pounds, and he was on the heart transplant list. Advanced cardiomyopathy. And that was the last time I saw him. So my guess is he didn't get the transplant. So, again, orthostatic hypotension, urinary incontinence, sluggish reaction, doesn't sweat. And that magnifies the problem because now you get the temperature aspects that are so problematic with it. And we'll talk about in diabetes, it's all about early aggressive control. Know someone who's a diabetic, doesn't matter whether they're insulin dependent or not. Love that person. Stay on top of it. They'll be. My wife yells at me. Not anymore. She yelled so loud. I'm a Mike and Ike addict. I have to go to Mike and Ike Anonymous. Hi, I'm Lou. I've been a Mike and Ike addict for 10 years. Hi, Lou. I'm sorry. Got to be upfront about that. It's a substitution addiction. It used to be good and plenty's.
Remember Mike and I had the fight and they broke up.
Oh, no. I try to be a counselor, get them back together. Mike, love Mike. Maybe they're a little, don't go there, Lou. Politically incorrect. You shouldn't, hey, shouldn't interfere with Mike or Ike. Okay, so we're going to get to that shortly with autonomic function, brainstem, spinal cord, hypothalamus, which basically is integrating and gathering the information. There are overrides, okay? It's typically subconscious, and that's the emotional center, the limbic center. You and I both know if somebody's just had a big fight or they walk into the room and you go, gee, what happened? Because they look different. They're flushed, they're eerie. You could just tell. Perspiring. And it's not like it's 95 degrees out. So brainstem, reticular formation, medullary centers, all of these things. You have to go through all that. Hypothalamically, as you can see, the anterior and the posterior are slightly different. Again, not a big deal for us, but it's more about what they work with. Heart, blood pressure, body temperature, water balance, and we're going to go over all of that stuff as we go through these additional systems, because we're going to do the heart and the blood vessel. Temperature is sort of generic, and again, the emotional responses, and that's what fight or flight is. When you react to it, and say, the old story, somebody cuts you off, you have all the physical reactions, but then there's also obviously an emotional component. So I know they're still using biofeedback. It was somewhat in its infancy. It was before the digital age. We were using oscilloscopes, and you could hook somebody up and they'd see a pattern on an oscilloscope. This is somebody we were doing with neuropathy. And they were doing it at the vet's hospital, trying to generate certain amounts of control, or if they were having spasms, trying to be able to control them, and being able to see a wave pattern when they had some surface leads on. So biofeedback's been around for a bit. I've never used it, so I don't know enough about it. Okay, and here you go. Hypotension, of course. Deficient control of smooth muscle activity. It can be sympathetic excess, and what happens is with that constriction, heart works harder. And because the heart is pushing harder, tears in blood vessels. Damaged blood vessel linings are the framework for atherosclerosis, where plaques of fatty materials to form because of inflammation first in the layer underneath the lining. That layer between the lining and the smooth muscle has a tiny layer of collagen in the form of, you might remember this, okay, basically the loose connective tissue. Very airy, loose areolar connective tissue. So when there's a tear in the lining, the collagen is exposed. That triggers clots. They start to pile up. There's an inflammatory component. That's why somebody taking a baby aspirin a day is fairly common for people who have had significant heart problems. It's just a generic, take a baby aspirin every day, because you resist clotting a little bit, because it doesn't allow for the platelets to aggregate. Yes?
So if people with pacemakers, are they encouraged to take baby aspirin?
I don't know. Short answer. Don't know. Pacemakers are much more common now. They're preferred because the medicines we used to use for arrhythmias were very, very harsh. I don't know. We should look it up. Sure. I don't think there would be anything adverse to it compared to me, just from my knowledge of it. Because that's always and years ago, it was people were very reluctant. Now it became much more involved. In my mom's day and age, when somebody got a pacemaker, technology was, you're like, well, in about 2 years, they're not going to be here. Now I think it's changed a lot. So again, there's different kinds of ways you can treat it. We'll go into that. There's better treatments. Fascinating disease, Raynaud's. There's Raynaud's disease and Raynaud's phenomena. Raynaud's disease is typically triggered by exposure to cold. It doesn't have to be like, oh, ridiculous freezing. It's sudden changes in temperature going from warm to cold. Like on a nice warm day, you jump into the pool, wherever you are, that's real cold. Non-heated pool. That degree of change can cause vasospasm. What'll happen is your normal color will constrict, so it'll become pale. And then when the spasm releases, there'll be, again, a pressure head builds up, and there's a lot of blood flow in, and it's difficult to return, and then it turns blue. Not. And yes, you use vasodilators. There's better ones today that we'll talk about a little bit when we talk about blood use, that are a good part of that. It can also be brought about not just by cold, but by sometimes a lot of excitement over illness. I saw it in patients. My first wife had that distinctly, and she got it wherever she was swimming with the kids. If they had that, and the temperature changed, and she was great in the water. I mean, she was sort of like stupid. Yeah, so our kids could all swim like crazy. But what'll happen is we used to call it the patriotic disease because you would go from normal reddish color to white to blue. That's Raynaud's phenomena. Raynaud's disease would be that. The phenomena is sometimes we will see that associated with other autoimmune. We used to call it connective tissue. So that was that was a little tell for that. You always, sometimes it was just this, the disease in and of itself. Sometimes it was associated with some type of significant underlying. That autonomic dysreflexia. This is a problem. Okay, uncontrolled activation of autonomics and quadriplegics, that's arms and legs, that's cervical fracture, and spinal cord above T6 again, more likely to be quadra than paraplegia. And that's a big one. So there's a lot of, obviously, anybody's quadriplegic is because you remember what the autonomic nerves are kind of below that. T1, the bulk of the sympathetic nerves are below that, so who knows how the signals are being impacted. There you can see, and Raynaud's is interesting, and I'll give you the distinction. It typically, you see that's called bilateral and symmetrical. Looks the same on both sides. Okay, so you'd see them blanching the same way, you'd see them thickening, and it would be hands or feet. I'd see both. There's another one that we used to, it has a feet, great name. Actually, it's called thrombo, I don't know what it's called. Meningitis obliterans. I saw this at the vet's hospital back then. Also called Burgers because not like hamburgers, burgers. It looks like it, but it's highlighted by asymmetry. It doesn't look the same on both sides. And when the fingers start to do it, eventually the blood supply goes. And we start to see gangrenous fingers from absence of blood supply. It's people who smoke. It's relatively rare, but in smoke, people who are chronic smokers, chain smokers. And we saw, when we looked at the guy with the black finger, ring finger, he had a cigarette in the other hand in the vet's hospital because you could smoke in the hospital. It's 50 years ago. Crazy. It's almost like an oddball allergic response to the constant input of whatever factors, not necessarily nicotine, but perhaps that, and other factors that cause vascular spasm. Very interesting disease. Oh, that's plenty. All right, we'll see you guys. We'll go down into the regular room, 141. I'll pick up. We'll get started on the endocrine because I don't know when the blood stuff is covered. I was going to do the blood, but I'll do the endocrine. What?
You do a written outline for the exam.
A written outline. Didn't I give you a study guide?
Yes.
Did you get it? What?
It's on,
If you get it, I'll find it. I'll send you another one. Happy to do.